Hey everyone, if you're a neonatologist, a pediatric resident, or part of the incredible staff rounding in the NICU, you are in exactly the right place today. In this explainer, we're setting the stage for a really deep dive into the brand new 2025 Pediatric Research Systematic Review on Neonatal Vascular Anomalies. We're specifically focusing on Cutis Marmorata Telangiectatica Congenita, or CMTC for short. I'm honestly so excited to guide you through this material because it is a real game changer. It fundamentally shifts how we look at newborn skin.
Okay, let's dive right into this. Picture this. You're examining a newborn and you notice this striking net-like reddish-blue pattern spreading across their legs. Now, every NICU practitioner knows that immediate little spike of anxiety, right? Is this generalized livedo just a benign reaction to a chilly exam room, or are we looking at the very first glaring sign of a much more complex, potentially systemic vascular disorder? Well, that is exactly the diagnostic dilemma we're going to solve today.
Here's our clinical roadmap for today's explainer. We'll quickly cover 1. The newborn skin dilemma. 2. Defining true CMTC. 3. Clinical presentation and asymmetry. 4. Unmasking hidden comorbidities. 5. The infant diagnostic algorithm. And finally, 6. Multidisciplinary management plan.
Let's start with Section 1, the newborn skin dilemma. To really understand the difference here, we have to look closely at the microanatomy of the skin. You can think of the cutaneous vasculature as being organized into little cones with an ascending arteriole right at the deep apex. At the margins of these cones, oxygen tension naturally drops. Now, when harmless physiologic arteriolar vasospasms happen, usually just from cold exposure, blood flow drops and you get these uniform, unbroken livid rings known as physiologic lividoreticularis. The key? It completely resolves when you warm the baby. But protracted, irreversible vascular pathology, that causes broken, asymmetric rings, and that is known as pathologic lividoracemosa.
And this brilliantly illustrates exactly what your eyes should be looking for. On the left side, check out that uniform, continuous, almost perfectly net-like pattern of benign lividoreticularis. Now contrast that with the right. Notice how the pattern is totally broken, irregular, and strikingly violaceous. That's pathologic lividoracemosa. When you see this asymmetric, irreversible pattern that simply doesn't fade under a radiant warmer, yeah, your diagnostic alarm bell should absolutely be ringing.
Moving on to Section 2, defining true CMTC. First up, a quick bit of terminology cleanup. If you've been practicing for a while, you might remember the term macrocephaly CMT syndrome. Well, we actually need to strike that from our vocabulary. The 2025 review clarifies that this is a total misnomer. The vascular findings in those patients aren't true CMT at all. They're actually completely different capillary malformations, like port wine stains. So, the modern accurate consensus is macrocephaly capillary malformations. True CMT is entirely its own distinct entity.
So the crucial point is how we actually nail down the diagnosis. I highly urge you to take a mental screenshot of these criteria right here. These are the Knost and Hoger diagnostic criteria. To diagnose true CMTC, you absolutely need the 3 major features: congenital reticulate erythema, an absence of venectasia, and this is key, absolutely zero response to warming. Plus, you need at least 2 minor criteria to seal the deal, which can include things like telangiectasia, skin atrophy, or port wine stains. Keep this checklist permanently in your clinical toolkit.
Which brings us to Section 3, clinical presentation and asymmetry. The anatomical distribution here is really fascinating. It isn't always just a cute little patch on a leg. While 55% of cases are, in fact, localized primarily to the lower extremities, take a close look at that 41% stat. 41% of these neonates exhibit generalized involvement. That is a surprisingly high frequency. Generalized CMTC presents a massive clinical burden, sometimes even involving the mucous membranes, and it's going to drastically change your whole management approach. Let's move to and see how this builds from where the disease is to what it actually does to the skin and the underlying tissue. Because CMTC isn't just a simple color change. 41% of patients suffer from actual skin and tissue atrophy. 32% develop limb asymmetry, and a striking 18% present with ulcerations right within the lesions themselves. Let's drill down into that 32% limb asymmetry figure for a second, because this specifically requires strict orthopedic monitoring.
The asymmetry in CMTC is predominantly hypertrophy. We're talking about affected limbs that are actually shorter in overall length, or, most commonly, have a noticeably smaller circumference, and sometimes by several centimeters. This means from day one in the NICU, you aren't just treating the skin, you're having to monitor the physical, structural growth of the child's limbs.
Let's jump to Section 4, Unmasking Hidden Comorbidities. 50%. I literally cannot emphasize this critical statistic enough. Exactly half of all the CMTC patients in the recent cohort presented with a comorbid disorder. This completely shifts our understanding of the disease, right? CMTC is not just a pure skin issue, it is a systemic concern. If you're only looking at the skin, you're quite literally missing half of the disease.
So, what exactly are these hidden threats? We can break them down into 3 categories, so you know exactly which subspecialists you need to consult for a comprehensive workup. You've got your cutaneous comorbidities, like infantile hemangiomas. You've got systemic issues, ranging from liver function abnormalities all the way to severe genetic conditions like Rubinstein-Tauber syndrome. But I want you to look closely at that top category, ophthalmologic.
Now, what's really interesting about this ophthalmologic data is that these defects are the single most common comorbidity, occurring in 27% of cases. We're talking about really severe issues like bilateral peripheral retinal non-perfusion and neovascularization. And here is the kicker. These infants are almost always entirely asymptomatic at diagnosis. No obvious vision issues at all. This drives an absolute urgent need for routine early eye exams for every single CMT patient, no matter how perfectly healthy their eyes might appear on the surface.
All right, Section 5, the infant diagnostic algorithm.
So, when your patient presents with reticulated skin, you're going to follow this clinical protocol step by step. First things first, apply a warm compress. If the lesion resolves completely with warming, great. You're dealing with physiologic Cutis marmorata, no further workup needed. But if it's unresponsive to warming, you are now on the clinical path to evaluating for CMTC, and you must immediately begin checking for those associated anomalies we just talked about.
And as this breakdown illustrates, the historical breadths of abnormalities tied to CMTC is incredibly vast. We're looking at everything from craniofacial issues like a high-arched palate or macrocephaly to neurological delays and even skeletal syndactylity. This reinforces exactly why a quick once-over just isn't going to cut it anymore. A thorough, head-to-toe, multidisciplinary exam is strictly required the moment CMTC is even suspected.
Finally, Section 6, Multidisciplinary Management Plan. Here is your specific, long-term action plan. While the vascular lesions themselves often stabilize or even spontaneously fade away within the first 2 years, managing the physical complications is a totally ongoing battle. These kids need routine annual ophthalmology screening. We might use laser therapy, like pulse dye lasers, to improve the lesion appearance. Stringent wound care is absolutely vital for that 18% who develop ulcerations. And for the limb asymmetry, we're talking aggressive early physical therapy for hypertrophy, and eventually orthotics or even surgical epiphysiodesis down the line to correct leg length discrepancies.
But we really have to remember that care goes way beyond just the physical. Visible, generalized skin lesions carry an incredibly heavy psychosocial burden. The distress, the self-consciousness, the social stigma, it all severely impacts the emotional development of the growing child. And frankly, it places huge stress on the parents too. Early psychological counseling and ongoing emotional support are literally just as essential as the physical therapy.
If you take away just one core message from this entire explainer today, let it be this quote: treat the patient, not just the patch. The skin is only the surface. Routine ophthalmologic screening and a dedicated multidisciplinary care team are absolutely essential to giving these kids the healthy, thriving future they deserve. So, I want to leave you with this final, provocative thought. The next time you're rounding in the NICU and you see a neonate with a reticulated, reddish-blue skin pattern, are you prepared to look beyond the surface? I truly hope this explainer has empowered you with the exact tools and protocols you need to do just that. Thank you so much for joining me, and keep up the amazing, life-changing work you do for these little